All right, good afternoon. Why don't we go ahead and get started. My name is Dennis Auckley. I'm a assistant medicine physician at the Medical Center for the County Hospital, Cuyahoga County, which is Cleveland, for Indians. And I'm part of Case Western Reserve University. I'd like to thank the Narcolepsy Network for having me come and speak today about something that really I think there's a lot of growing interest in, which is what happens sort of with patients with narcolepsy in the perioperative time period. I'm going to give you a little bit of history about how I got interested and involved in this. Review some of the literature, what we know about patients with narcolepsy undergoing surgery, installation, anesthesia. And then we'll talk about also some future directions, and I'm also going to mention the project that maybe some of you might have been involved with, the survey study that we did about a year ago, patients with narcolepsy and their personal experiences with undergoing anesthesia and sedation. This is a little bit of a homecoming for me. I actually grew up about an hour northwest of here in West Lafayette. I did my medical school and my medicine training just here over at IU. It's amazing how much Indianapolis has changed since then. This is not around. It's a pleasure to be back. Just a couple of quick disclosures that I have to make. I have written a couple of sections for Up to Date. It's an online medical reference source for physicians. It has to do with inpatient medicine, a little bit on narcolepsy, but shouldn't cause any conflicts here. And if any of you are planning on taking the American Board of Internal Medicine sleep medicine exam, there will be no questions from this test. I'm obligated to say that because I'm test ready. So what I wanted to do in about the next 40 minutes or so is cover sort of these broad topics. So talk about what the possible implications could be for patients who have narcolepsy and its therapy. So there's almost two overlapping but separate issues there. And then review your experience with the perioperative setting based on the survey study that we performed. And then I'm going to talk about some recommendations that our task force has sort of come out with. I put those in quotes because there's not a lot of evidence, as you'll see, these recommendations really solidly hands on. But there's sort of more consensus, things that seem to make sense, recommendations. And then a little bit about future direction about where we want to go, what we want to look at with regards to narcolepsy in the perioperative setting. So as I mentioned, just a little bit about the history. So this is a collaborative effort that started really kind of looking at this. So one of the medical advisors to the board of directors, Dr. Earl Farr, approached me a few years ago. Apparently Narcolepsy Network was interested in looking at narcolepsy in the perioperative setting. And at the time, and I still am, part of the Society of Anesthesia and Sleep Medicine. I co-chaired the clinical committee, and our job there is to sort of disseminate information about what we know about things in areas where we don't know to sort of start to investigate a little bit. This society has been around for only about 8 years, and it's actually a fairly new society that grew up all around the issue of sleep apnea and perioperative management because there's been some very bad outcomes in half the patients with sleep apnea. And so a group of anesthesiologists, sleep medicine doctors got together and decided we should probably start looking at this, and so we formed this sort of specialty society looking at that. But since then, the group has really grown into looking at all sorts of aspects related to sleep and perioperative medicine. So ranging from, how does anesthesia manage sleep? How is sleep impacted by anesthesia? Sleep apnea, biological processes by which these things happen. To more recently, we're starting to look at other sleep disorders in the perioperative environment. So the time was kind of right. Dr. Carr approached me and we decided, okay, let's form a collaborative task group to look at this. So we formed this group. You probably recognize some of the names on here. It's an interesting mix of both anesthesiologists and sleep medicine specialists. You probably recognize Dr. Munoz and Dr. Thorpe. They're leading experts, thought leaders in the field of narcolepsy medication, narcolepsy and medication. Shelley Hirschner's sleep physician and neurologist at the University of Michigan. Dr. Gay is a sleep specialist at Mayo. And Yves Duvalier is a narcolepsy expert from France, so it really has an international flavor. And we have some anesthesiologists on here. Probably won't recognize any of the names. Some of you may have heard of Dr. Chung, who's gained a lot of fame for developing a screening questionnaire for sleep apnea in the perioperative time period. So her name is somewhat synonymous with that. She's from Toronto. So why should we even be concerned about this? So as you all know, narcolepsy is relatively uncommon. But patients with narcolepsy are going to have surgery, they have to undergo procedures. Everybody does at some point in their lifetime. And so perioperative fighters are going to encounter patients with narcolepsy. So it's important that they have some sort of understanding of the disease as well as the medications used to treat it. It's not expected that perioperative providers are going to be diagnosing the case of narcolepsy. Their understanding and suspect is pretty rudimentary, and unlike sleep apnea, where there can be very, very catastrophic outcomes in the near term, it's not really clear that that's the case with narcolepsy. So we wouldn't expect them to be screeners for this disease. But there has been concern raised. This actually goes back a while, decades in fact, but it's been kind of just intermittent little drips and drabs of information coming out about what happens with patients with narcolepsy when they undergo anesthesia and sedation. So there's a number of potential problems which could arise. So we're thinking about this from a hypothetical standpoint, what could happen. And then some of this is supported a little bit in the literature, but we'll talk about why that is or where that comes from. So obviously, a hallmark of the narcolepsy is hypersomnolence, excessive sleepiness. There have been some case reports about patients with narcolepsy having delayed emergence from anesthesia. So how the anesthesia itself may actually impact narcolepsy. But it also may be coupled with the fact that medications are being withheld during the recovery period, so that could lead to prolonged periods where patients may not wake up. The additional concern about increasing perioperative cataplexy, sleep paralysis. So this kind of makes sense. Surgery is a stressful event, right? So we know that cataplexy is often triggered by strong emotions, so we can be anxious about surgery, pain, things like that can set off cataplexy, sleep paralysis, and as well, medications used to control those conditions may be stopped by a perioperative provider, not really having full understanding of the medications. There's also potential for drug-drug interaction with anesthetics, as well as, again, stopping the medications in the perioperative time period could potentially lead to withdrawal syndromes, which could be very complicated. There's been interesting literature coming out, just sort of touching the surface right now, mostly epidemiologic, but suggesting that patients with narcolepsy have more chronic pain, and their pain tends to be more disabling. So there may be some effects actually of hypertreatment on how we perceive pain. And so that's an area of active research that's going on. And then I'm going to throw this term around a little bit, autonomic dysfunction. I don't know how familiar you are with that. But this basically is sort of what regulates our baseline metabolic processes of blood pressure, heart rate, things like that. There's growing evidence suggesting that patients with narcolepsy have some dysfunction of their autonomic control system, particularly with regards to blood pressure and heart rate, which, thinking about it in the perioperative time period, could be quite significant. Because those are things that we're watching very closely in that time period. And as patients are dropping their blood pressure, becoming very hypertensive, or the heart rate slows down too much, they have big prompt positions to act. And so that can be an issue in patients with narcolepsy. So we sort of looked at a number of questions. So one is just first off, are patients with narcolepsy at risk for increased adverse events in the perioperative time period? So I'm going to go through the literature that we found related to that. And what's the perspective? So patients with narcolepsy, what's been your personal experience with undergoing sedation or anesthesia? So we'll talk about that in the survey study. And then also just kind of what do perioperative providers really know about narcolepsy and its medication? What are they doing in practice? And that's actually, as of yet, still somewhat of an unanswered question. And then what should we be doing, with your medications? Should they continue? Should they be withheld? Should we be doing extra monitoring? All these things are the questions that sort of came up. I thought I'd just start with the case report. This is one of the first case reports. It's a little bit confusing. I've read this several times. Still trying to figure this case out. It didn't clearly state the patient had narcolepsy. This is back in 1977. So, if you weren't at Stanford, probably most people would not have recognized the problem. But it's very interesting. This was a lady who had sleep paralysis was her primary manifestation. And then she came in for ovarian cyst removal. During a prior hospitalization for a surgery, she had an episode of sleep paralysis and actually went CPR. And you'll see from a minute in the description about why that might have happened. But CPR is not a benign thing. We've done it before. If you do CPR well, you often break some ribs, causing like trauma. So that's concerning. So she came in for this surgery. She actually had an uneventful surgery. Everything went fine. But in the postoperative period, she experienced 3 episodes of sleep paralysis. Ironically, her husband was a physician. And he told the team he was there when this happened. And he told the team, no, this is her sleep paralysis. And this is what they described these episodes as being. She would be non-responsive, glassy-eyed, ready for breathing. So if you weren't aware, didn't know this was going on as a medical provider, if I came in front of a patient like that, I'm going to start doing things because I'm very concerned. This part doesn't make sense. For some reason, they gave her IV physostigmine, an alpha agonist, and this seemed to bring her out of the sleep paralysis episodes, which she even describes, oh yeah, this was my sleep paralysis episode. But this was reported in the literature, just sort of thrown out there. This is 50 years ago. So there's several steps I'll take you through in terms of what we have done and what we know about this. So the first step that we decided was let's review the literature. So I'll show you that first case report, but what's actually out there? What kind of information do we know about narcolepsy and perioperative time period? So we set out to do what's called a systematic review and meta-analysis. So a systematic review is basically a very organized, structured, methodological review of the literature to try and make sure you're not missing important, relevant information. It's often, the data search is often done by librarians who are highly skilled in this. Pulls out all the information. That's, they do word searches on narcolepsy and hypersomnia and cataplexy and match them with, perioperative care and medication, etc. And they come with all these things, and then we start excluding studies that aren't really relevant. So initially, some of these things are just looking at the title, and maybe narcolepsy, but not really surgery, maybe a surgery issue, narcolepsy, so we toss those out. And then we get down to the nitty-gritty, and we start actually looking at the studies very closely. And so we have this flow chart of how we get to the bottom line of what studies we're going to review. And so what you can see after all that, so they actually started out, go back here, almost 4,000 titles. Got down to 19 studies, which really met what we consider to be the inclusion criteria to examine narcolepsy in a perioperative setting. So this is a description. So we actually, the task force did this study, and it's been published in Anesthesia and Analgesia last year. And I'm going to run through this briefly to just let you know kind of what we're sort of up against with this topic. So those 19 studies, the N is the number of patients that are actually reported. So only 49 patients, so this is really sparse literature. So that tells you that most of these cases most of these reports are single case reports, where somebody sees something, they think it's important, so they put it out there. Unfortunately, it's a very low quality of evidence. When you're looking for associations and trying to make decisions, obviously what you obviously would want is randomized controlled prospective studies, which will give you the most solid information. So the information is from the get-go very limited. There were 2 small case series in here, one which had 27 patients, which tells you most of the remaining cases were single or 2 patients being reported. None of the reports were prospective, they were all after the fact, and none had control groups, which makes it big complicates, when we're trying to draw inferences from the information. So a variety of medications were used as stimulants, but most of this is older data, so they're using a lot of the older drugs, so methylphenidate and amphetamines. Really, nothing in the review that we did, had patients on modafinil or modafinil, some mixed amphetamine salts, etc. Interestingly, which we were a little surprised to find, was that most of the patients had their stimulants continued in the perioperative time period. Just anecdotally, and we'll come back to your experience, that may not always be the case, but this is a select group of patients. None of the patients were on sodium oxybate, so that's a big hole in the literature, as you'll see as we go through this information. A lot of these things predated the widespread use of that, but it's just a patient, there haven't been any reports related to this. There were a small number that were either on SSRIs or TCAs, antidepressants that can be used for cataplexy. And so it's a very small number, and it's very hard to get a draw complete. And then a variety of surgeries were performed. So patients had anywhere from ENT surgery to neurosurgery, orthopedic, abdominal. It's just a real mix of surgeries. So it always kind of throws a monkey wrench when you're trying to do sort of comparison and draw associations. So this is background data. The average age of the patients was 47, so some middle-aged. Most were diagnosed when they were younger with narcolepsy, which makes sense. The plus minus are the confidence intervals, so it tells you there's a wide range. Many of the subjects were identified when they were in their teen years, some in their 30s. Slightly male predominance. Just over the criteria for obesity with the BMI, body mass index of 31, but a pretty wide confidence interval there as well. Most of the patients, probably based on their young age, were relatively healthy otherwise. About 30% of patients had some hypertension, a very small number had COPD, chronic obstructive pulmonary disease. There was some hypercholesterolemia, migraine, vascular disease, and a small number of the subjects reported, but by and large, a fairly healthy patient population, which limits some of the confounders you might expect that could cause other perioperative complications. When we talk about anesthesia, most of these patients are doing general anesthesia, which means we're going to totally put to sleep. And most of the time they're using inhalational drugs. We'll come back to that. It could be a little bit of an issue in terms of recovery from the medication. And then a small number were given total anesthesia via IV, so just injected through your vein. Many patients for a variety of surgeries have to be paralyzed for the surgery, so the surgeon can do their work without you twitching or moving, even when you're heavily sedated under anesthesia. So those drugs usually require reversal agents. So about 20% of the patients were given medication to reverse the paralysis that was induced. So I looked at the complications, and so this was just ended up being what's called a systematic review. Ideally, we want to do what's called a meta-analysis, which means we're going to pool all the data, and then you do an analysis on that from a statistical standpoint, see if we can establish associations. The problem was that the literature is so heterogeneous. I mean, there's so many different types of surgery, different types of anesthesia, different types of medications used, that we couldn't do, and different types of outcomes reported. You'll see that we couldn't do any kind of formal statistical analysis. So it's kind of like, this is what we found, try and draw a conclusion from that. So some of the patients, there was one patient with hypertension when I had low blood pressure in the operating room, and you may think that probably happens occasionally in the operating room. But certainly based on that topic I mentioned earlier about autonomic dysfunction, possibly could be related to their underlying narcolepsy. One patient had perioperative, and then one patient that had cataplexy during a lower extremity procedure. They were given a regional anesthetic that set them off, and so they went in a complete cataplectic episode. For perioperative providers that don't know what cataplexy is, you can imagine how they may react to that. Postoperatively, about 31% of the patients that are reported adverse events. But again, without control groups, it's a little bit difficult to know exactly what to make of it. So the most common complaint is postoperative pain. Most people have pain after surgery, but these patients felt their pain was not well controlled. Could be, theoretically, makes sense that there may be more of an issue in patients with narcolepsy, and we'll talk about certain perspectives in a minute. Nausea, vomiting, fever, that's really that. Those things can really be tied very well. Excessive sleepiness, so worsening of their baseline sleepiness. Sleep paralysis, again, hypertension, the cardiovascular, and some respiratory issues as well were noted in a small number of patients. And that may be relevant to some of the other things we'll talk about. When we were doing this, we also came across two specifically obstetrical case series. So we separated those out because it's very different. These are actually large studies, so 486 deliveries, so it's much bigger than the 49 patients we talked about earlier. One of the problems here, again, the control was just comparing type 1 and type 2 narcolepsy, and not comparing them to patients who did not have narcolepsy. So what they noticed with the type 1s is that more weight gain during pregnancy, which kind of falls into line with the whole issue of hypocretin deficiency, compared to glucose processing, and more anemia in the type 1 group. Interestingly, there are 5 episodes of cataplexy described during deliveries. So as many of you know, delivery is can be a very emotionally charged event. Bringing a new person into the world, a lot going on, and so that certainly could set off cataplexy. One reports the patient in the status cataplecticus, which can be difficult to control. And then 2, it's not really clear what happened here, but this may have been a case where the OBGYNs, patient went into cataplexy and they sort of panicked, not understanding what cataplexy was, and then took the patient for C-section thinking something else was going on. Subsequent to that publication, this study came out of the Mayo Clinic, which actually is probably the highest level of data that we have, because this is a case control study. Some problems with it, of course, it's retrospective, they're looking backwards, so standardizing outcomes becomes difficult. But they did control it for patients who do not have narcolepsy, and they matched them based on age, gender, type, year of surgery. So it's actually pretty good. So you're saying, okay, we'll need some patients who have narcolepsy, and with some controls, we have basically the same issues going on related to their surgery, they're the same age, etc. So I had a little thing here, the p-value. For those who aren't familiar with statistics, this is sort of the accepted statistically significant range. If it's less than that, it means there's more than 95% chance of what they're finding is real. And so that's in the field of science, this is the accepted norm. So in the patients who had narcolepsy, they found they were more likely to be on stimulants, no doubt. No big surprise there. More likely to be on antidepressants, probably related to cataplexy, although there could be other issues, but that was statistically significant. More likely to have sleep apnea, which we'll come back to in a minute, but that's not a huge surprise based on other recent literature. And then, reassuringly, they didn't have any difference in their other comorbid conditions or other diseases. They were not heavier by BMI measure, and then they used similar anesthetic techniques, so it's roughly the same number underwent general anesthesia with inhalation agents versus IV. Again, only one patient. So they were looking back at their database at Mayo Clinic, going back a couple of decades, but only one patient was on sodium oxybate. So again, a big hole in the literature because we're missing this information. So what they did was they looked at the complications they found. So they looked at 4 areas. So one was intraoperative, the PACU, which is the recovery room, and then the first 48 hours, which they call the phase. First 48 hours, and then their 30-day outcomes. So they want to see, are the patients who have narcolepsy having more bad outcomes? And basically, they didn't find any difference, with the exception of there were more emergency team activations in the patients with narcolepsy in the first 48 hours. So these are called rapid response teams or emergency response teams, RRT. So they found more of those, 5 versus 2, in the patients who had narcolepsy. And these are related to, again, the thing about this, the autonomic dysfunction issue. So low blood pressure, fast heart rates, infections a little hard to tease out there related to narcolepsy. And then also the respiratory depression issue coming up. So again, these are small numbers. 76 isn't a huge study, but it's kind of the best information we have out there. Subsequent to this, there was also another OBGYN study, single institution retrospective. Again, that limitation, that was controlled, 1 to 3, 1 patient narcolepsy with 3 controls. They looked at 25 potential patients and 59 pregnancies and deliveries compared to 75 controls. And the patient narcolepsy were likely to have single pregnancies, were likely to have pregnancy-related diabetes, which kind of makes sense. I'm not sure how you parse out the single pregnancy issue, but the pregnancy-related diabetes could be related to the weight gain and metabolic issues. But they didn't see any difference in complications during or after the delivery. 6 of the patients continued on their stimulants during pregnancy, so most of the stimulants are class C, so it's usually a patient-to-physician discussion about whether they should continue their narcolepsy medication during pregnancy. So a small number were, and none were on sodium oxybate. So, in summary, the current literature really is very limited, mostly retrospective case reviews, cases or case series. Most of these are not controlled, with the exception of a couple of those recent studies. Probably the strongest issue that may be signaling right now is there may be some issues related to underlying narcolepsy and the autonomic dysfunction. Could that sort of manifest or come out more boldly in the postoperative time period, which can lead to potential problems? The possibility of worsening of other narcolepsy symptoms, so worsening sleep paralysis, cataplexy, and how the therapies are impacting these things isn't entirely clear. So, like I said, there's kind of single case reports, a few things here or there, not well controlled. Probably the best thing might be the deliveries with increasing cataplexy, but even that's a very small number of patients. And we have no information on the patients with sodium oxybate, so that's a big hole in the existing literature. So as you can see, it's not very high quality. There's enough here to sort of get us thinking maybe we need to look at this better, do some better studies. The good news is, unlike sleep apnea, nobody's dying, so it's good. But there are still some potential serious problems that could arise in this setting. So the second thing that we decided to do as a task force was to get your guys' input. Patients with narcolepsy, what's been your experience with undergoing surgery? So we talked about this already. Your perspectives obviously are valid and important and may not be captured in things like small case series or small even case controlled studies. So some of these things, given the frequency that's possible, you may need very large controlled studies to actually tease these out. So we did a survey. So we generated a survey, Dr. Carr, Dr. Hirschman, and myself. We sent it around to colleagues, and then we sent it out. We sent it to all the members of the Narcolepsy Network. And we posted it also on Facebook. So one of the limitations is we can't tell how many people actually had access to it. But we think we got a very good response. Over 1,000 of you responded to the survey, which is fantastic. I mean, there's very few survey studies where you get numbers that low. And then just over 1,020 reported diagnosis of narcolepsy and having undergone a surgical procedure at some points. So the concerns that were raised, so the darkest bar here was a sort of scale, very concerned, somewhat concerned, not all concerned. The major concerns that were raised by you guys was the ability to be able to continue your medications. So was your surgeon going to stop these medicines? I'll tell you anecdotally, after the survey, the first time I spoke on this, one of my patients had come to clinic to see me as narcolepsy, and she had an orthopedic procedure, and her surgeons refused to give her, and she was on Ritalin. And I'm not entirely sure why, they never consulted me. I wasn't aware she was going to surgery. She said she was out of it for 3 days, she couldn't wake up. And so, this is a real concern of hers going forward. If she would have surgery again, they need to know they need to continue her medication. And then about 60% or so were concerned about having problems waking up after surgery. So am I going to be able to wake up in an appropriate time fashion? Am I going to be out for days related to the anesthetic or possibly withholding my medications? Interestingly, the majority of respondents said that they weren't counseled in the preoperative setting. So some of this relies on the sleep docs. If we know surgery is coming, although I think even sleep docs, by and large, this is a relatively new area, may not be aware of some of these issues. But a lot also goes back to the perioperative providers who see in the PSC clinic are patients being counseled on what to expect given their underlying disease. And so the minority, only 20% said they were counseled that they may experience increased sleepiness. Less than 5% thought they were counseled about the possible cataplexy and issue of rate of sleepiness and anesthetics and avoiding driving. And then in terms of other outcomes that were reported, so the biggest problem, again, coming back, inadequate pain relief. So majority of respondents said they did not feel they had adequate pain relief. One of the other shortcomings of this is we don't have a control group, so if I were to survey everybody who had surgery, how many of them would say they didn't have adequate pain relief? It may be similar, it may be less, I don't know. But 80% seems like a very high number. In addition, the number reported they had trouble waking up after their surgery. That was almost 40%. And then smaller numbers reported that they had increased cataplexy, that they were continued on their medication. So unlike those case reports where most of the patients were continued on their stimulants, the number reported they weren't. And then a small number also reported they felt they had some withdrawal related to the medications being withheld. So, this is important information. Again, like I said, there's some limitations to this survey study. It's based upon, participants' recall of the events. So we don't have solid evidence to say these things definitely happen. There may be some bias in recall and whatnot. Anyway, so we're in the process of revising this manuscript, and hopefully this will be published within the next 6 months or so. So one of the other things we want to look at is what do perioperative providers, anesthesiologists, surgeons, the PSC, CNAs, and all that, what do they actually know about narcolepsy, and how do they manage patients with narcolepsy during surgery? So in terms of their comfort level, we actually have no idea. So there's been a couple of surveys. I participated in one looking at anesthesiologists and what they think about patient sleep apnea. So as I mentioned, that's been an area that's really raised a lot of alarms. Most hospitals have gotten interested in that because they've had a very bad outcome, not to brain injury or death related to a patient's sleep apnea. They had a bad event after surgery. So we've done surveys of anesthesiologists and sleep apnea, and many of them, despite how common sleep apnea is, are not very well aware of sleep apnea and the management and not clear what to do. I suspect if we're to survey, and we're planning to do this, as soon as we, especially meeting next week, and this will be one of the topics to discuss, is that probably most of them don't have much of an idea about narcolepsy because it is not very common. You see these patients infrequently, not being familiar with medications. And really probably should be coming back to us as sleep providers to discuss this with us. But it not happened, that survey has not happened yet. So based on that available information, we sort of came up with, we thought were sort of some summary recommendations, which we thought, again, these are more kind of what we think based on the literature that's out there would make sense. Some of it is, in a sense, sort of hypothetical, and we don't know for sure. There's not great data. But in terms of preoperative counseling, for most patients, and there are going to be exceptions to this, for most patients, they should be allowed to continue their medications in the perioperative time period. This includes taking your stimulants up to and then shortly after surgery. There is a possibility of worsening symptoms, and you should be counseled about avoiding driving. Most patients undergoing anesthesia should be counseled about this anyway, but maybe more prolonged avoidance for patients with narcolepsy. And then in terms of the medications, again, we'll talk about continuing these to help control symptoms and prevent withdrawal. You can have stimulant withdrawal. There are some case reports of this happening in patients without narcolepsy who are on stimulants for other reasons, undergoing significant rebound withdrawal when their stimulants were held, which can cause a lot of problems. Very high blood pressure, very fast rate, their heart rates, very fast heart rates, agitation, things like that. So that could be a potential problem. So we recommend continuing those. In general, from a safety standpoint, I think perioperative medicine is moving in this direction anyway, but probably having a lower threshold, and we advocate this with our sleep apnea patients as well, is that to consider regional when possible or general anesthesia. So as to not put the patients under total anesthesia. This avoids some of the drug-drug interactions and may limit some of the intraoperative issues. And then also, so I didn't discuss this earlier, but one of the things that's been raised is the possibility, and there's a couple case reports about this, of patients with narcolepsy, when they have gotten their stimulants, having an increased intraoperative awareness. So they get anesthetics. Normally we put somebody under, the anesthesiologist assumes that they're under, but perhaps related to those stimulants being on board, that they are more aware of what's going on around them. And you don't want to have that happen. You want to be helped if the surgery is taking place. So using bispectral analysis is a way an anesthesiologist, it's sort of a shortcut to a sleep study almost. They can use this in the operating room, and they help them to measure the depth of anesthesia. So that could be something to be considered in patients with narcolepsy. And then it can also be useful, if cataplexy were to occur, right? So as opposed to saying, oh my God, you're not responsive, we better start CPR and all that sort of stuff. If you have this on them during that time period, you can see that they're actually still mostly awake. And again, consider your IV anesthetics instead of the inhalational anesthetics, which may cause more prolonged problems with waking up after surgery. And also, it's been looked at in a mouse model of type 1 narcolepsy and shown that this will, inhalational anesthetics will prolong emergence. So using IV and shorter-acting anesthetics whenever possible makes sense. And again, the field is kind of moving in this direction anyway, but avoiding the long-acting opioids. So, like to avoid opioids if we can, but obviously opioids are still necessary in many cases. But if you're going to use them, particularly in someone who's already prone to sleepiness and possibly worsening sedation with these things, use shorter-acting agents as opposed to using the longer-acting ones. And then if there's worsening narcolepsy symptoms in a perioperative setting, there should be consulting the sleep medicine doctor. So one of the other areas I'm interested in is sleep medicine in the inpatient setting. And I'll tell you, this doesn't happen in a lot of places. Most people think of sleep medicine in an outpatient field. But there is a growing interest in starting to look at things more in the inpatient setting. This is one area that I think would be useful. For pregnant patients, risk of cataplexy delivery, again, consulting sleep medicine, and then also the issue of sodium oxybate. So very interesting. In talking to colleagues, there's no literature on this. But what I have found is that some of my colleagues have called Jazz Pharmaceuticals and have a pharmacist on call 24/7 that will help with managing sodium oxybate in the inpatient or in the perioperative setting, so they can give advice in terms of dosing of the medication, when to consider stopping it, if there's confounding medications. So that would kind of make sense and probably should involve sleep medicine, but again, we don't have any literature on it. I've already touched upon this a little bit. Sleep apnea and narcolepsy and sleep apnea can coexist. A number of my patients who have narcolepsy have sleep apnea. Most of the time they were diagnosed with narcolepsy, and then over the years, they gained weight, they got older, and they developed sleep apnea. And so it's not something you miss, but the symptoms sometimes overlap. So you have hypersomnolence, and one of the issues is someone thinks, oh, it's their narcolepsy, and doesn't think to reevaluate the patient. And so there's been a few studies showing that the rates of sleep apnea in patients with narcolepsy is higher than the general population. And if sleep apnea is present, this may have an additive or worse effect in the perioperative setting, and something that we probably need to be thinking about looking at. Screening for people is difficult, but those of us as sleep medicine providers should be certainly aware of this and looking for it. And most patients undergoing surgery, a lot of institutions now are undergoing preoperative screening, looking for sleep apnea if it's an elective surgery to try and identify that prior to the surgery. So future directions, you probably already guess at a lot of these things just based on what I've talked about. So far, there's a lot of holes in the literature. So one of the things we want to do, and there's actually a step looking at this, a small step looking at this with the JAMS pharmaceutical database, but are patients with narcolepsy truly at risk for increased complications? So we need actually probably larger, multi-center controlled studies to really evaluate this and get a better handle on what's going on. What about the medications? The medications themselves cause problems, stopping medications cause problems, reducing doses cause problems. So I think we need to, like I said, there's sort of a signal of some issues, theoretically might make sense, but really need more